What I learned in those first years of practice through that team-based approach to healthcare was that patient came first. So if you have a surgery or you're injured or you've had a heart attack or a stroke or some other major event, even minor event, one of the most important things to do is start using your body again. Sometimes you have to induce a little bit more pain to loosen up tissue, for example. Many of the techniques that we use actually may stimulate a little bit more inflammation, which may again stimulate more healing.
A lot of the techniques that we use in physical therapy, right, attempt to get more blood flow and nutrients to the tissue. That's the purpose of the movement. Welcome to the Healthcare Revolution podcast. Today we are talking about the evolution of our profession, the physical therapy profession. And the reason it's important to the public is to understand why things have changed over time. And the topic that we're really diving deep into is why delaying PT really matters. Most people will start at the wrong end of healthcare. They'll go to a specialist, an orthopedic surgeon, and then be essentially directed back to the start. And it's a huge delay in the actual healing process. And we want the public to understand the importance of starting at the beginning of the continuum. This last year, we became primary care providers in physical therapy. And the reason for that is because we are the entry point to what we call musculoskeletal care. That means anything pain or injury, we are the first line of defense because we can save you the most amount of time, money, and the majority of these conditions can get better in physical therapy alone, without imaging, without steroid injections, without medication. And we want to be on the front line to prevent a lot of the illnesses and issues that we create later in life. So excited to have my guest on. He has been a physical therapist for 47 years. He has seen the evolution of this profession from a bachelor's degree to a master's to a doctorate, and he has a PhD as well. He's been on faculty at the University of Utah since 1987. Keep in mind, that was 2 years before I was born.
Ouch.
Just aging him just slightly. But I really hope that emphasizes the amount of wisdom that we're bringing to the table here. He has made a global impact on our profession. He's been our national American Physical Therapy Association president and made decades of impact both in Utah across the PT profession. If you have been in PT school, you know him, you love him, you know about springboard diving and all of his jokes, and we're going to talk about all those things today. But our main focus is to make this public-facing and to really answer your questions on the importance of starting with physical therapy with pain and injury. So Dr. Scott Ward, welcome to the podcast.
Yeah, thank you, Brad. It's an honor to be here.
I've been wanting to have you on this podcast since I started it, and you've taught me such valuable lessons in very short bursts of time through my education. I remember we talked earlier about when I was in my undergrad and how I just called up randomly as a junior in my undergrad and said, I want to interview Dr. Scott Ward. Didn't know he was the chair of the PT school at the time. And you were very inviting, and you invited me into your office and coached me. And just looking back at that, I just think, would I do the same? And I would absolutely do the same because people have done the same for me. But I had no idea of the level of caliber you were at or the position that you're in, but you were so gracious in sharing your knowledge and wisdom to me as a young entrepreneur and student, and I was so appreciative of the time that you took.
Well, thanks. I've sort of, positions aren't really important. It's what you do with the position that makes a difference. And so I always tried to be as open and inviting as I could. Absolutely.
And you've done such a great job at that over the years. I remember one time, this is a story to kick off the podcast.
No.
I didn't know really what anxiety was. I was not an anxious person most of my life until I got into PT school. And there was this test-taking skills that I had no idea I needed to develop. And I remember I got so anxious one time in Scott Ward's pathophysiology class, which pathophysiology is this pretty much how disease affects the normal function of the body. and he taught that course, and I remember it was a true and false question, and I answered it as C. So true was A, false was B, and I answered C.
Oh, well, congratulations.
And I remember going to Scott's class. I'm like, Scott, I'm struggling in your course, and you were talking to me about, well, what's the problem? And talk to me about that. And I said, I put C on this answer, and I'm frustrated by it.
Well, rightly so.
Yeah. And there was a lot of coaching that a lot of professors did with me on test taking skills, because that was my biggest issue. I didn't understand the question that was being asked, and that was a lot of times why I missed it. But again, Dr. Ward was so helpful and so gracious through the experience, and that's how he's been my entire career, and been so gracious with his time.
Well, apparently not very helpful if I made it unclear that there wasn't a C on a true and false question.
I want to say that they've taken those C's out of the test now. Yeah. There's only 2 options.
Yeah, I hoped I only provided 2, but
it was A through E, I remember.
Oh, yeah, I see.
The bubbles.
Well, I typically used to tell people, look, a multiple choice question is really basically a true and false question. Mm-hmm. So you go through it, and what you do is
you eliminate one.
You eliminate the most obvious ones you can, and you're generally left with a couple that are challenging.
Yeah, absolutely. Well, tell me, as we dive into this topic of delayed physical therapy, what are kind of the first things that come to mind in your 47 years of PT?
Well, I maybe to make the story as quick as I can, when I graduated physical therapy school in 1980, which I know is long before most people who will listen to this podcast were ever born as well. I joined practice in the University of Utah Burn Center as a physical therapist, the second physical therapist there. And I received training that became invaluable to me for the rest of my practice and educational career. And that was cooperative team healthcare or medicine. We rounded frequently 2 or 3 times a week on every patient.
What does rounding mean?
And rounding means that the team gets together. So it was there were the surgeons, the pharmacists, the nurses, the physical therapist, occupational therapists, if there were one. There weren't at the time. Was a small staff. And they go and talk about each patient, talk about their care, where their standing is. So everybody understands at that point in time what the patient situation is. And so the rounds are really when you go around to each patient, either physically or you just talk about them.
And for those that don't know what this is an incredible thing that we do in healthcare. And it's a little bit harder when we're in an outpatient setting.
Yeah,
but what Dr. Ward here is talking about in a hospital system, and we're working on this outpatient as well, but everyone is able to share their viewpoint from their expertise and their concerns with the patient's care moving forward.
Yeah, and update everybody on. So as physical therapists, we would tell the rest of the team, what we were doing and what our plans were and what some of the obstacles were that we were facing. And the team would then talk about that. Same with the surgeons. They'd talk about their concerns about wounds healing or whatever it might be, and so on and so forth. And so we all shared that information. And what I learned in those first years of practice through that team-based approach to healthcare was that the patient came first. And everybody had a role, a critical role. It wasn't just the doctor. It wasn't just the nurse. It wasn't just the PT. It was everybody. And everybody listened to everybody. Everybody questioned everybody. Nobody got defensive. Why did you choose to do that?
And questioning more to seek understanding.
Right. And so nowadays, when in the world of electronic records, we dream of electronic team rounds, if you will. Mm-hmm. So when I go to my electronic files for my personal health care, I can communicate with any of my providers. What I hope is that some of my providers are actually looking at what some of the other providers have said. Now, I know time is short, which is why the rounding worked in person because it was assigned time and everybody had to be there. They were assigned to be there. So I think the importance that I found in this approach early on in my career was that everything is better if everybody's focus is on what's most important. And that was really the patient and their care. It wasn't about whether or not nobody praised me for good work. It was all about, was my work making the patient better? And so when you talk about in your introduction the importance of accessing appropriate care at the right time, one of the things that I would say is, again, in my practice in the burn center, and this has been now echoed in lots of medical literature about early mobilization. What that means is moving early. So if you have a surgery or you're injured or you've had a heart attack or a stroke or some other major event, even minor event, one of the most important things to do is start using your body again, getting up and moving and encouraging your systems to function. And I will tell you, when I started physical therapy in ICU settings like the burn center, early mobilization was wholly discouraged. Patients were to rest and not move, but my colleague PT Andy Schnebley and I had a different idea of that, and we started actively moving patients on the day they were admitted. And
how was that accepted or not accepted as you discussed it?
In our burn center, fortunately, we had progressive surgeons, progressive people, and they were willing to give it a try. It made sense why we shouldn't just rest people. But I'll tell you, in the burn community, the broader burn community, that was not well accepted. And I would say for about 7 or 8 or 9 years or so, there was a lot of, when we would go to meetings and present on this early activity, there was really a lot of pushback.
Yeah,
and now it's standard of
how
care.
How painful it is to move.
Well, but it's painful to move. I mean,
it's painful
to move.
Right.
And not moving it keeps the pain at bay, but when you have to finally move, it's worse because your soft tissue is shortened. I mean, all these things that happen as a
let's dive into some of that physiology. Tell us about, and let's speak more general, and you can be a little specific with burns, but as far as delaying movement, if you have an injury, what happens to the scar tissue? What happens to blood flow? What happens to anything physiologically when you stop moving?
Well, it's with any injury. It doesn't have to be a burn. It could be any injury. The tissue is damaged somehow. Cells in the tissue are damaged. They have to heal. And part of that healing process is reorganization of the tissue. It may be regeneration of the tissue if you're fortunate enough to have injured something that can, well, in regeneration, what I mean by that is the tissue heals to the same kind of tissue it was before. So, for example, you'll know when you get a little scrape on your skin. It's just a small scrape. Within a couple of weeks, it heals and the skin looks normally, and you never knew you had a scrape. That would be regeneration of your skin. There are many tissues like muscle, many tissues like ligaments and things that can't regenerate. And when they're damaged, the way they heal is by the body laying down scar tissue. It's a long process, but when you're injured, there's a process called inflammation. Everybody, I think, understands inflammation, and it's a physiologic process that is induced with any injury. And pain is a part of that process. And pain is good because we know we've hurt something, but when it hurts, we don't want to move it. We don't want to disturb it, which is okay for a short bit, but the reality is it is going to hurt no matter what you do. And you can work within pain parameters. And keep your movement going, and over the long haul, that will improve your function, and it doesn't increase your pain, even though at the moment it feels like it does.
Yeah, and tell us, you've seen the evolution of our profession, and you've heard people joke about physical therapy as pain and torture. Tell me where you feel like that term has been adopted, and could we take a moment just to kind of abolish a little bit of that?
Well, my brother's favorite joke, and he tells it to me over and over again, is the old one about what's the difference between a physical therapist and a terrorist. You can negotiate with a terrorist.
Yeah.
Well, frankly, I don't know whether you can or not. Fortunately, I've never known one. But I think it's a joke people make because not all physical therapy hurts, but most of what we do creates discomfort and often pain. The issue, though, is the person, the patient, the client, whoever you're working with, already has some level of discomfort or some level of pain. They don't want more.
Mm-hmm.
But sometimes you have to induce a little bit more pain to loosen up tissue, for example. Many of the techniques that we use actually may stimulate a little bit more inflammation, which may, again, stimulate more healing.
And a lot of the techniques that we use in physical therapy try to attempt to get more blood flow and nutrients to the tissue. That's the purpose of the movement.
Yeah, and that's also the purpose, frankly, of the inflammation.
Mm-hmm.
The response does that. It increases blood flow to the area. But that blood flow also increases the function of a lot of cells that are doing repair, including cells that lay down scar tissue, etc. Also, all the tissues that are involved in that healing area contract or shorten, get smaller, so they tighten up.
What is that purpose of the contraction process?
I don't know that anybody knows it for sure. I believe, in my mind, evolutionarily, that part of that is to try to contain and decrease the area,
surface area
of the damage, so that there's less surface area that needs to be healed.
Would you say it also is adapting to demand of what you're requiring out of it too? Say, for instance, I have a cut, and we see these at different areas in the body, but you have a cut on the skin, and you maybe put your arm in a sling, and all of it shortens down around that area, around the wound, because you never really straighten it out. Would you say it adapts to that demand?
Well, all tissue adapts to whatever circumstance it's in. And so if you were not injured and you casted your elbows bent and you left them there for really a week or two, and you took the cast off, you'd be stiff. Mm-hmm. And that's only because all of the muscle and other soft tissue around the muscle had adapted to the new length. The reason I can bend and straighten my arm so easily is because all of the tissues in that structure are used to those ranges of mobility, right? And if I shorten that down, the tissue will just adapt.
Yeah.
So everybody who's had a fracture and been in a cast, people who have sprained something and been in a splint, all know that they come out of that device stiff, and they have to work through that.
And that really highlights the importance of early motion or early activity. I think about someone that, I used to work in the acute rehab center at St. Mark's, and we'd have someone that had a hip fracture from a fall. And I did a hip fracture study with Dr. Bobby Briggs in PT school, and it was all about early mobility. You could imagine how breaking your pelvis would induce a lot of pain.
Yeah.
Right? And then our job, the problem is these people get in bed and they don't want to move because it hurts. But that's going to actually induce more pain, because when we get them moving, it hurts even more.
I also think, to understand it from the patient's perspective, if you say fractured their pelvis, I mean, that's a big deal. It is painful. Mm-hmm. They can hardly move anything without the pelvis being affected. That's almost the center of our whole core, right?
Mm-hmm.
So you can't move a leg, you can't move an arm, you can't breathe, you can't move anything almost without affecting a pull on your pelvis. So it's going to hurt.
Yeah.
Now, the reality is, from the patient's perspective, you have to think to yourself, okay, well, why don't you should get up and move? It's going to make you feel better. But they've just broken their pelvis.
Mm-hmm.
First of all, it really hurts, so they don't want to cause themselves more pain. But secondarily, give them some credit for thinking, well, I don't want to get up and move because what if that dislodges the fracture?
Mm-hmm.
It's unlikely that would happen depending on the nature of the fracture. But all of these things come to people's mind. What if I dislodge the fracture? What if I tear the scar? What if I have an artificial hip? What if I get up and move it wrong and it pops out, or whatever it might be? I mean, things have evolved so much. When I graduated from physical therapy school, and we saw patients post-orthopedic surgery, both total knee and total hip. I'll start that over again. So when I graduated from PT school, and we saw people post-orthopedic surgery,
So hip replacement,
hip or knee replacement, nowadays, well, I'll say nowadays, and I'll go back to centuries ago when I first practiced. Nowadays, you don't leave. I mean, it's rare that you stay a night unless you have some kind of complication.
Getting you out of the hospital
Normally,
as soon
they're
as
saying,
possible.
okay, you're having surgery, you're leaving, you're walking out that afternoon if you had morning surgery. If you have afternoon surgery, maybe you spend the night and leave the next morning. But it's a turnaround, and you're out, and you're walking, and you're up, and you're moving. When I graduated and we saw patients post-operative knee replacement or hip replacement, they were in hospital for at least a week, inpatient. And we moved them a little bit in bed, and we would sit by the bedside. It would take a week for them to finally get up and start moving around. Now, part of that might be the progression of the devices. I mean, I think the hardware that is used now is much more forgiving for those kinds of things. And the techniques have improved. It's the best part of medicine, PT included, is nothing. It all evolves to be better.
Yeah.
I mean, it's incredible. Anybody who says,
and a stark contrast to this is I would do open heart surgery with patients.
Yeah.
And the requirement is they're up in 4 hours.
Right.
Their surgery now. Like,
yeah, but that was not the
their
case.
Chest and we're getting them moving 4 hours later.
And that was not the case a couple centuries ago when I graduated PT school.
And
I mean, the
so
reality is
important,
that's the whole point. And so we talk about any injury. I know in outpatient, there may be a focus on things like low back pain and orthopedic or musculoskeletal kinds of issues, but it's the same with neurologic injury like stroke or other debilitating neurologic diseases that you just don't wait. I'm going to tell you an interesting story. So I was recently in Central Asia and had a chance to meet with a neurosurgeon in Uzbekistan, and I'm not boasting about being there. I was there and had this interesting conversation, and this neurosurgeon said, we don't have physical therapy here. We need it because right now, if I have a patient who's had a compromise of the brain, a stroke or something else, and he's done some neurosurgery on them, he said they are in the hospital for a week or two and they're sent home, and they may have somebody see them or help them move 6, 8, 12 months later. He said, and by then it's way too late. We need physical therapists to start with them early. And so, I mean, here's a physician who's essentially dreaming of the opportunity to have a physical therapist present in his hospital to be able to get these patients up and moving and functioning quicker. And the data are there's so much data about early mobility in all of these things.
Tell me about muscle mass and strength. What happens in such a short period of time. We've used the term bed rest, which bed rest we're going to define as a medical provider saying you need to stay in bed. Why has that evolved?
Yeah, and by the way, bed rest is a misnomer. I mean, nobody ever stays in bed. They all go to their lounge chair and turn on their TV.
Yeah, take a few steps, go to the bathroom.
Yeah, maybe.
Yeah.
But the muscle and every tissue, by the way, we sort of focus on muscle because it's so critical. It's the tissue that moves us. It allows us to stand. It allows us to move. It allows us to feed ourselves. I mean, muscle is critical to our survival and our mobility. And muscle really, if it's inactive, its response to inactivity is to shrink. So muscle cells are simply nothing but there's a certain kind of protein, a series of proteins, and if you don't use it, your body just says we're not using it, so we're going to shrink those cells. And that's if people hear about atrophy, that's what atrophy is, when these cells shrink and you don't use them. Now, they don't necessarily go away, but if you don't use them, I don't know, this old adage,
what's the difference
you use them, you lose them.
Yeah, what's the difference between atrophy and sarcopenia?
Well, sarcopenia is a type of a muscle loss, generally driven by something. Atrophy there's lots of different kinds of atrophy. There's sarcopenic atrophy, but there's also the one we typically refer to when we're talking about increasing early mobility and activity is to decrease disuse atrophy, which is when you don't use it. Your body adapts to not needing it.
Essentially making the cells smaller because we're not using them. It's adapting to the demand versus like the cell is actually dying off.
Yeah, and there is trauma-induced sarcopenia. Sarcopenia is the loss of a muscle cell, basically, but it may not be the total loss of the cell. It may be the loss of the function of the cell, whatever. But the important part is whenever you have injury, part of what your inflammatory response, this inflammation I talked about before, is to protect the area. And that's probably one of the reasons things contract or get smaller, is to try to protect the area, make it smaller. But we don't move. And part of that is I would think evolutionarily, is to try to help give the body time to heal itself. So it's sort of a physiologically induced bed rest, if you will.
Yeah.
But it doesn't, what data have shown is that it doesn't hurt to move.
Yeah. So
now, there are some things you shouldn't move. So, for example, if you have a fracture of a bone and it has to be held in place a period of time for that bone to knit itself together, you shouldn't be moving it because you're not giving it time to heal.
Yeah, and I know you're probably thinking as you're listening to this, it's like, okay, I need to move more.
Yeah.
How do you know how to move? And how do you know how much? What's the dosage of movement? And I want to pose a question here. What's the role as a physical therapist in helping the patient understand when they need to immobilize, what we're talking about, bone, holding the bone in the same position and protect, versus optimal loading over time? Because we've heard terms like RICE, which is rest, ice, compression, elevation.
Yeah.
We also had the doctor that coined the term come out and say, we don't rest, we need to protect it, but we need to optimally load it. That means getting it moving, right? And we've had new terms come out, in the past few years as well. But tell us the PT's, the physical therapist's role in helping a patient determine what is too much and what is too little.
Well, so I mentioned before, we've got to we have to give our patients credit. I mean, they're in a situation which to them is bad, right? I mean, they're hurt, they're probably scared or concerned, they don't understand what's happening, they're worried about hurting things more. And
causing tissue damage.
Yeah, they're worried.
Permanent.
I mean, they're worried about if they create more pain in what they're doing, isn't that doing more damage? Mm-hmm. I mean, and that's very fair. We all would think that, and so we have to give them credit. physical therapists know about this healing process. They understand the musculoskeletal system as well as any healthcare provider does. They're trained deeply in that. Mm-hmm. They're trained deeply in the neurologic system as well. So, the cardiopulmonary system, which is your heart and lungs and the skin. And so we know a lot about these systems. So if we go to the musculoskeletal system, one of the things that a physical therapist can do is say, well, I understand the mechanism of injury or how you were injured. I understand the healing process. If there was some surgical intervention, I've communicated with the surgeon. I understand what was done. And so I can help guide you through, whether it's pre-surgery or post-surgery, whether or not it's just right post-injury. So if somebody came to see you off the street, directly, you do what every good diagnostician does. You do an examination to try to determine what's happening, and you do it very thoroughly. You understand the limitations of the system in its normal capacity, and you understand what that injury is and how that will limit that function, maybe for a period of time, or why it's limiting the function right now.
Yeah, and I want to add a piece to what you're saying. Yeah. Your course on pathophysiology is how disease affects the normal system.
Right.
So the PTs have to know all these diseases as well.
Yeah,
and how that can change the normal process.
Right, and they may not be an expert in all those diseases, but no physician is either. I mean, mm-hmm. Physicians have these glorious subspecialties so that we can find out very clearly what might be happening about your heart.
I remember the textbook was this big.
Yeah, if you go to a cardiologist.
3 inches deep.
Yeah, and so the way a physical therapist works is they do a thorough exam, and then they understand the constraints of mobility based on what's happened. That can be a neurologic thing like a stroke or some muscle or joint trauma or whatever. And so they understand that, and they do this exam, and then they determine what the functional limits are that you have, why you can't move as much, or what your concerns are. And then the goal of the physical therapist is to work with a patient to regain their function or their mobility, to be able to do things as pain-free as possibly. And we always like to say we'll get back to normal, but everybody's normal is different. And that's another thing a physical therapist will do, is talk to the patient about, well, I understand what the general normal is, but what's your normal? Mm-hmm. And so a physical therapist is uniquely qualified to be able to look at healthcare directed at function and mobility.
Yeah, and where do you feel, with your 47 years of being in PT, where do you feel PT should be in the continuum now?
Well, I can go back to right where I started. We should be right in the middle of it. I mean, this may not be what you want me to say, but we're no better than anybody else, but we're no less than anybody else
That's
either.
Exactly what this is all about.
Yeah, so I mean,
not putting us at the front, but not putting us on the back, but to be the decision makers of what is best for the patient at the time.
So I'm going to tell you another story. I mean, not a story.
As long as it's a springboard diving story,
no,
which I think we need to get to that.
Well, no, that's a little, I don't know. We'll see. But so it's not really a story. It's a vignette about what happens to all of us as physical therapists. I used to tell this to students, and you might remember I mentioned it. I would generally mention it before a student's first Thanksgiving break. So students would generally get 2 or 3 days off from school to go home for Thanksgiving or to go somewhere and celebrate the Thanksgiving holiday. And so I would spend a few minutes talking about what I called Thanksgiving Day referrals, or really Thanksgiving Day consults. Mm-hmm. So if you're any healthcare provider, it's no different for physical therapists. And I use Thanksgiving as a focus, but you can go to any event, family reunion, a church group, just pick any kind of group. And they know you're a physical therapist. And I tell students, they know you're a physical therapist student. So here's the deal. They're going to come up and they're going to say, Brad, man, I must have slept funny. I got this crick in my neck. I can't move my neck and it hurts right here. Or, I must have tweaked my back somehow. I can't remove it or whatever. You come up with a little complaint. And do they say, well, I'm going to go to my doctor first, then I'm going to come see you? I mean, no, you're a physical therapist. They assume you're an expert in what you're learning or what you've learned. They're going to say, so what should I do about it? Happens at every holiday, at every gathering. There's never been in my 47 years. Well, what I appreciate is the fact that they come to ask me.
Yeah, that they trust you to ask you questions.
Right.
Yeah.
And sometimes I'll say, well, I might recommend that you try this and this. I'll ask them a few questions. I can't do a thorough exam. And these requests for assistance are, for me, they're a compliment, right, to me and my profession. But that being said, and the reason I bring this up is people really don't necessarily feel like they need to see a doctor to come see us. They've got a problem. And, well, you're a PT, so help me with my neck or my back or my elbow or whatever it might be. And that's wonderful. But then what a physical therapist will do is they'll look at it and they'll say, well, I think this will do. But one of the things then we always will say is, well, if this doesn't help, give me a call and let me get you to somebody who I think could help you. Because maybe I'm not the right one. And I can help people with some musculoskeletal stuff, but it's never been my specialty. So I can help with generalized. But if somebody has a real issue that I don't know the answer to, I'm going to refer them to a trusted PT or a trusted MD or a trusted PA or whoever I know who I think could give them the attention they deserve and need. And if I'm in practice, if I were seeing someone and there was a problem that came up and I knew it was outside of the scope of my practice, my responsibility, and I taught you this all in that class, your responsibility is the patient. So if there's some question you have that you don't have the answer to, your job is to refer and get them to somebody who can help them.
We clock that time. Yeah. We need that for APTA. I completely agree with you, Dr. Ward. Like, our responsibility is to triage, to make sure they're in the right spot, and if they're not, our responsibility is to refer and find them a place that can help them. I had a patient just yesterday, and she came in for her shoulder, elbow, and hand, but the main priority was her hand. When she closed her hand, you could see one of the extensor tendons, which is just a tendon on the back of your hand. It would actually dislodge, and that's not my specialty. So immediately I send a text to one of my hand PTs. I send the video over, and he says, this is exactly what's wrong with her. Yeah, you can either send her down to me in Provo, which we're in Salt Lake, which wasn't ideal, or you could send her to Dr. Gowski's office. They can splint it there, but she'll need a splint, and likely it will heal. It'll heal in a very good way to where she wouldn't have problems, and if not, then she'll need some surgical intervention with it. So I called up my buddy. This is all during the visit. I called up my buddy, who's a PA at hand and ortho and injury now, and he's like, yeah, just send her over tomorrow. We'll get her splinted. And she was so grateful. And this process that we do can collapse time for people. It can delay how much suffering they have, because this gal, she had an appointment with a surgeon 6 weeks from now. Literally, we collapsed time, and now she's literally in his office today at 11 a.m. Yeah, it's 11:08.
Well,
and that's the goal, right, is to do it for the patient.
This gets me back to, again, my very first initiation to practice was in that team-based approach. When at the end of talking about a patient, if somebody said, well, they've got this, they're complaining of these heart issues, a referral was immediately sent to cardiology. I mean, so it was sort of like, okay, well, we're taking care of the whole patient, and we can't take care of the whole patient. No one of us can cover everything. So part of it is building a community of people that you know who you can refer to or suggest that people see and make the connections that you said you make. I mean, triage is a great word. When we do an exam of a patient, we're triaging that patient. We're getting that patient's need. We're getting an idea of their needs. We're getting an idea of their concerns. We're getting an idea of their response to what's happened, and that tells us really whether or not we can help them. And PTs can help a lot of people, but PTs can't help everybody with everything. Now, you had said something about getting this patient to this hand therapist early, which is another point. We've talked about early mobility and early function during this podcast. And the problem is if that person had not sought help and not been referred for help, and they had this tendon that was displaced or whatever the problem was, not knowing anything about it, I don't know what the issue is, but that would have continued to create a problem, would have continued to create inflammation, would have continued to probably become further damaged, leading to less function or the person's unwillingness to move just because it either hurt or was uncomfortable. So what happens is if people wait, things generally don't get better. Now, we always hear, oh, you have a little back pain. Give it a few weeks, it'll generally work itself out. Well, maybe that will happen, and often it doesn't. And so they adapt to whatever the pain is and move differently, and then they end up with other sorts of hitches in their get along. But the reality is our healthcare system struggles with taking care of a problem quickly.
Yeah.
I mean, an emergency room is for emergencies, and they've become glorified urgent care providers, right? But we want a solution fast, and our system almost is against that because it takes time to get help.
It takes effort.
So we need people to be able to, we need people, providers, who people can access to try to get answers to their help quicker.
This is really remind me of, I had 3 of these yesterday, Scott.
Well, there you go.
So I want to share these 2 other stories because I only treat around 15 patients a week now, not very many, and I had 3 just yesterday. I'm coming to realization, and I hope if you're listening to this, it's really highlighting the importance of using this team mentality. But I had this gal that came with some wrist pain. I was treating her for a different condition, but she came with this wrist pain. She said, I can't extend my wrist to do a push-up. It hurts. And I looked at it, and I saw that there was a big bulge, which in PT school I learned that as a cyst. So I called up a provider, and I said, hey, can you get this gal in? I believe she has a dorsal cyst in her wrist, which is just on the backside of her wrist. Got her in. Turns out it's a big cyst, and they're going to remove it surgically next week and sew it up, and she's going to be good to go. And we'll work on the rehab after that. So that was one. Literally got her in. She's been dealing with this for 5 years, and we are coming to a solution within a week.
Yeah.
Right? And we build those relationships with those surgeons, and they get them in quickly, and there's that access point. So our role is to improve access for our patients. The second story was this patient's come in to me, and she's 3 to 4 weeks in with her rehab. She actually had a surgery scheduled. She had a cyst on her spine, and the surgeon told her that she needs to remove the cyst and fuse the actual section of her spine to be able to stabilize it. And I said, okay, well, that might be. Have you thought about getting another consult and just getting another viewpoint? I'm like, that could be the best option, but maybe not. I said, would you like me to refer you to someone else just to get another viewpoint? She said, yeah, absolutely. She called the office. They couldn't get in for 6 weeks. He's my friend. I called him up. I said, hey, is there any way you can at least just get your eyes on this patient, review the MRI, and just see if you align with this other surgeon? He looks at the MRI, says, let me get her in. Got her in literally 3 days later, just fit her in on his schedule, and he disagreed with the other surgeon. He said, I think we can remove this cyst and you'd be totally fine. And she was so appreciative. She's like, this gave me so much peace because I felt very torn and I felt very uncomfortable and I felt sick about the first option. But I had another option, and now I feel so peaceful and I feel good about my situation. I'm just so grateful that you helped me through that.
Yeah, well, part of what I'm hearing is two things. One is, first of all, not any one person has all the answers.
Mm-hmm.
But we've somehow...
I like to think I can fix a lot, but I couldn't fix those three.
Well, you
but it's
I'm
not my
going to
job
tell
to
you,
fix
you don't
them
have
all
all the
either.
answers.
Yeah.
I don't have all the answers. No one person has all the answers. But more importantly, what you talked about was relationships and respect and trust.
Mm-hmm.
Part of what was developed in those early rounds that I talked about before was trust. And we trusted everybody to question us.
Mm-hmm.
We trusted everybody to listen to what we had to say. We respected people's opinions.
Mm-hmm.
And sometimes we challenged them, but we respected them. So the point I guess I'm trying to make is you may get something you want. So say now physical therapists in Utah have earned this ability to be primary care providers, right? Well, it doesn't mean anything if nobody trusts us to do that right.
Yeah.
So how do we build that trust? We do it right. And we respect our colleagues for maybe their early lack of trust because we haven't built that trust up. But you've got these providers that you've developed these relationships with who trust you. So when you call them and ask for their advice, first of all, that tells them that you trust them, and then they trust you because you called them for their advice, right? So they know that what you're not doing in your clinic is seeing somebody who you're not sure you should be seeing until you get some more information. So, I mean, human nature is interesting. We really thrive on trust, but somehow or another we feel like we have to know more than, I mean, we can't allow ourselves to not be smart. And we should allow ourselves to be smart, but also realize that we're never smart enough. And there's always somebody who knows more about something than we do. Now, I know a lot about certain things.
Utilize those resources as well.
I know a lot about stuff, but I can always find somebody who knows more than I do. And the reason I know as much as I know is because I asked a lot of questions and I sought a lot of trusted advice.
Yeah, I love that. As we kind of wrap up this conversation, I want to kind of end with two questions.
Yeah.
What do you hope every patient understands about early mobility that we haven't talked about yet? And then I'll ask the other question here in a minute.
Well, the most important thing about mobility in general, when we talk about it early, I would just say consistent mobility. I mean, when you hurt, there's a reason that you hurt, and that is something's been damaged and it's repairing itself. But it will continue to repair itself through guided movement. So generally you'll have a physical therapist say, well, let's work within the parameters of pain. And a physical therapist, get back to your point about torture, isn't there to make you suffer the highest level of pain you've ever suffered. They'll move you knowing it will hurt, but they are going to preserve you from exquisite pain. Mm-hmm. I mean, sometimes you may feel it, but the movement is necessary to be able to allow the tissues to adapt to the mobility required for you to be able to get around.
And ultimately decrease additional suffering through lack of ability to move or lack of ability to control those movements.
Well, the reality is if you succumb to bed rest or the bed rest of the pain creates or whatever it might be, and you lock yourself down into some position that's totally comfortable until the pain goes away, when you start to move again, it will be harder to move because you'll be stiffer, and it will likely be painful to move. And so you can either postpone it or you can get through it. And the reason physical therapists are good at this is because they'll help guide you. They'll help coach you through this. Yeah. And they know what's happening.
Yeah, I love it. My last question is to providers, and that's healthcare in general. The healthcare is evolving so much, and you've seen the evolution through an entire career and through retirement. What advice do you have for young clinicians on the evolution process and having to adapt to the demands of the community over time? What advice would you give them?
My advice is just what I said. Be willing to admit you don't know everything. Keep searching for more data. If you don't know the answer to something, look for the answer. Ask your trusted sources. Read the literature where science is trying to give you answers, knowing that science is not the truth. Science is the search for truth. And so you should spend your practice life being a clinical scientist. You should be searching for truth to make your patients better. And so don't quit asking questions. Ask questions. Don't think that makes you feel stupid. If I had a question for your surgeon friend or your hand therapist friend or whatever, you're saying, I don't really understand this. Can you help me understand this better? Guess what that makes? They don't think you're stupid. They, in their mind, they're saying, well, I'm really glad you called. Can I take a look at it, or can I help you with that? So don't be afraid of thinking that a question makes you sound stupid.
Yeah. I'm going to quote you. Dr. Ward's quote of the day is that science is not the truth. Science is
it's the
never-ending search for truth.
Absolutely. And we discover something, and then we discover that we had part of it right, and part of it needs more search.
Yeah.
And that's what science is all about. I mean, and people who expect a definitive answer for something will seldom get it.
Yeah, I love that. Well, thank you so much for joining us
you're
today,
welcome.
Dr. Ward. And thank you.
Great pleasure.
I hope I can speak for a lot of our profession across the nation, even globally, of the impact that you've made. You've made a drastic impact upon my life, and I'm so grateful for the many hours, the thought, the intention, and the heart you put into building the future generation of our profession and also improving the current profession. You've made such a drastic impact upon all of us, and I'm forever grateful for it. And thank you for joining us.
Yeah, that's very kind. Mine's been a life of blessing. I've been really lucky.
Well, we appreciate you. Thanks for joining us on the show today.
Yeah, you're welcome.